we'll begin with the overall that currently in the world, as you heard Dr. Kasom say, we have, right now in the world, everything is about data and technology, and not just in oral health and between the disciplines, whether it's maxillofacial, pediatrics, periodontics. There's a large inkling on technology, pretty much everything about our lives, including the length of this Zoom meeting, the number of participants, how good I am at Amharic that I'm trying to learn. Even in sports, I mean, from the time of Gabriel Haile Selassie and Eliud Kipchoge's. For those who know, Eliud Kipchoge is an athlete in Kenya, and he did the 1:59. And for those who watched it, you could see all the statistics going out and how he's breathing, the design of the shoes, to the point that even Nike has designed new running shoes. So just to bring us into focus that technology and getting the right quality of data in the right quantities is really helpful and convenient in this day and age. Plus, it also helps us make decisions. To bring us closer home, we had the COVID pandemic still ongoing. And if you recall how each and every day would get what I'd say data, but it is news or information that X number of people in this country, X number of people here, this vaccine has responded in this number of people, this age group, to the point that research brought us towards getting a vaccine. Not only the vaccine, but also the management and control of the COVID pandemic. The first response and how we reacted to it was based on the amount of data. We all had the same amount of data, the same amount of quality of diagnostics, and we could tell, this area in Diadawa is getting a spike of COVID. Can we quickly intervene and go do that? So based on that, I think we can tell that good quality of data and harnessing technology and communication between not only regions in a country, in public service, and even within countries, we can have a huge impact. And you can see how the numbers of COVID went down. And I only wish we could do the same in oral healthcare. So that's just to bring us towards getting the concept of data and use of technology in oral health or health in general. That said, yes, I'm from Kenya. Some people say I look part Ethiopian. I don't know how true that is, Dr. Fasi. And brings us to the topic of the day, which is the quality of oral health data in electronic medical records. And I did a bit of reading and I saw that in Ethiopia, we have a bit of research in electronic records from Haramaya University in Diadawa, I think by Bebe Tolera and company. So there's a few articles that have come out and a few suggestions and conclusions on how we should improve our electronic medical records. So I hope you learn a thing or two from our Kenyan experience and improve our practice as we go along. That said, that is the outline of our presentation today. I'll keep it brief. I know it's a Sunday evening and we want to rest and enjoy our injera. So I'll keep it brief and to the point. So the topic is the quality of oral health data in electronic medical records. The title was slightly longer, but I've tailor-made it so that we can really get the concepts. So that's the outline. We'll just have 4 to 5 thematic areas, one being an introduction and background, research design and methodology for the work I did, the findings and discussions on the same, and we'll make a few conclusions and recommendations for practice, which hopefully we can implement and keep a global perspective in our practice. So by way of introduction, we have had the concept on what this data does and how it has an impact in our practice, and what is an electronic medical record. We know it is a systematic longitudinal and integrated document that is done in a computer. Not to go into the technicalities, but you type letters, but a different format enters the computer and is stored as information. So from collection, storage, processing, analytics, and how we communicate this information is quite important in our practice. And we know that it happens at the point of care when you're together with the patient, regardless of the field you're in. I know Kasaun may have challenges in maxillofacial surgery, typing what an ameloblastoma is, or a 4 class 3 fracture. But that's when it's done, and there are ways of tailor-making it. And important in this day and age is the security of this data. It must be secure, so it's not tampered with, and readily available to the members of staff that are using it. This definition is from healthita.gov from the USA. And as we know, this contains vital information about our patients, the information, how we're going to treat them, and it is shareable between disciplines. And currently a project I'm working on how we can integrate oral healthcare and medical healthcare using the same records, since we see the same patients. Discussion for another day. So we know that technology, we all have mobile phones, we all have different apps and calendars and reminders and alarm clocks. And you know that this technology helps to automate and streamline our workflows, not only in healthcare. So you can get reminders and send reminders to patients. You can identify which patients to treat based on this electronic data. And it's not just rumors or politics. We know that these records are evidence-based. They have been shown to improve healthcare, and they help us make decisions not only in a clinic level, hospital level, but also a regional level. That's why I've put stakeholders. So it's not just us as medics. So you can even have the pharmaceuticals, the people supplying plates, the people giving grants. So long as we have a solid level of data, we can easily have scrutiny, surveillance, and response to diseases, as I mentioned in the example of the COVID pandemic. Good, so I think I've preempted this slide. What it does is it gives us a seamless connection. I'll just get my pen there. So you can see in the realm of healthcare, if you're seeing a patient and you have good quality records that are well integrated, from the doctor to the entire hospital, to the pharmacy where you're giving your drugs, the nurses, the dentists, whether it's an emergency or maxillofacial, all the way to internal medicine, pediatric care, family care, and community oral health care. So these are important tools that can guide us not only in Ethiopia, all the way to Addis, Gabon, South Africa, and all the different countries in the world, as happened in the COVID pandemic. Not to say that so far there are no statistics being collected. You have statistics being carried out from WHO, FDI, various organizations are collecting data and giving us reports on how well we are doing or how areas to improve, especially in oral healthcare. I don't know how many of you know that 42.7% of all children in Ethiopia have oral health afflictions. How do I know that? It's from data collected. And what it does, it informs decisions going forward. Yeah, I hope we have grasped that concept and we are getting there. So as a background, we know that this information globally is important and it's critical for us to make decisions in healthcare, whether it's for the individual patient, especially when you're doing multidisciplinary care. If you have a patient who has a maxillofacial condition with perio and pediatric aspects and oral pathology, doing the diagnostics, that management of data is quite important for us to give wholesome, good healthcare for our patients. As my moderator informed us all that it's a growing system. We are still adapting, not only in Africa, but even in other countries in the world. And everyone is coming up with systems and implementing systems. But globally, one major concern is what's the quality of data? What's the definition of dental caries in this region? What's the definition of fluorosis? So that in mind affects the quality of data. So if we're all speaking different languages, as I'm trying to speak Amharic, if I try to speak Kiswahili, we will all get lost. But this delivery of presentation is working because we are talking in English. So essentially what I'm saying is, a major concern globally is what is the quality of data? Are we speaking the same language in terms of disease classification and the rest? I know there's the international classification of diseases, but sometimes it speaks a different language to what we are maybe discussing in various countries. That said, technology is going to help us, not only in practice, but also in reporting and research. So issues that have come up from the data is that it's, first of all, not adequate enough. We're not recording as much information as is supposed to be done. had mentioned standardization. You'll have 3 to 4 definitions of every disease or classifications, grading, right? And thirdly, one of the hugest issues is integration with other services. So you'll find a patient being treated for diabetes. I don't know how many periodontists are in the house. We know periodontal disease and diabetes are one and the same with a bidirectional relationship, but you'll find that the internal medicine clinic have their own medical records. The dental clinic has its own medical records, or they're both on paper. So you find that we miss out on giving the quality of care that is required for our patients. So having that in mind, I looked into it and saw that there was actually no guideline in our country regarding what is the way that we should take our dental records in terms of electronics, so that we can speak the same language, so that if I want to know how many maxillofacial fractures were in Gambela, I can just click in a button on the Ministry of Health, Ethiopia, and I can see, oh, okay, this number of issues are increasing in Addis. Can we make restrictions to prevent and control? So on a Kenyan perspective, I saw that as an issue, and I said, can we evaluate what is the quality of data that we are collecting, and how can we improve and strategies to do that? And we will later implement and see the impact of this improvement. All right, so this brought us to the purpose of the study. I hope I'm not going too fast, Dr. Kasaun. If I am, I can slow down. They say Kenyans talk quickly. I hope we're okay. Right, okay. So that brings us to the purpose of the study, which was to assess the quality of EHRs that are recorded in the first encounter forms, because that's where the patient begins. So if you take your first history and it's not adequate, that is carried along to the other clinics unless someone takes a better history. This study was carried out at the hospital in the directorate that I lead. And I think this was mentioned that we serve a large catchment area, about 25 million people as a hospital. And I'll just put that map there into context so that we can see the little red dot there is where the hospital is. It is Kenya, the country I'm in, and that's Ethiopia up there. I don't know if you people send us patients. Okay, and Uganda, Kampala. So that entire region, you'll find patients, especially along the borders, end up at our hospital. So we'll now talk about data. Let's erase this. Okay, so we'll talk about data quality. And data quality has at least 6 aspects that we'll say now this data indeed is of good quality or not good quality. And the 6 aspects are shown in the chart in the middle of the screen. You have completeness, uniqueness, consistency, all the way to timeliness. So completeness is the degree to which the data is available for you. So did you mention all the parameters required for it to be complete? And in terms of uniqueness, this is data regarding Dr. Fassi, so it's not mistakable with someone else, it's unique. Consistency means that between data sets, you're asking about the same things, so that every patient will be asked, do you have a history of this? Do you have a family history of this? How many times do you brush? So consistency is important in our histories so that we have a good flow and quality of data. Validity is it valid? Is Haile Gebrselassie better than Paul Tergat? So does it really fit your requirements in terms of format, type, and the range? And accuracy, is it accurate? Do you have the correct records to say, yes, this is the number of people who have this affliction in oral health, and that informs our decisions as clinicians and managers. Even at the clinic level, if you're running a clinic and say in this region, in terms of reality, we're getting a spike in children who have fluorosis because of borehole water, or there's increase in caries because the kids are having more sweets in school. Does it represent the actual reality in the patient or in the area? In terms of timeliness, very important. Right now we're having, is it the Marburg virus and cholera and other pandemics going on? Do you get the information in time before these diseases spread to the patient? So you can see there are quite a number of aspects to data quality, and there are actually more, but these are the key ones. And for purposes of the study, I looked at the two main parameters in quality that really have to be there, and that is completeness and consistency. In research, sometimes you have to have your limitations so that you don't put so much that you can bite. Okay, so we'll go into those parameters one by one based on the specific objectives. So first of all, we evaluated the completeness of the health information in those encounter electronic medical forms. And then we analyzed the level of consistency between the range of data that we sampled. How consistent and how complete were they? And we'll go into them after seeing the research design and methodology. So based on the range of the study, this was a descriptive retrospective design study. Sorry, just give me a minute. Okay. So we had a large sample of about 400, and we ended up doing a systematic random sample on 338 retrieved electronic records. We were using a different off-the-shelf system that was quite rigid and was open in some areas. So it was up to the clinicians to actually type their history without a standardized format. Yeah? And the duration of the study was between January and February last year at the Directorate of Dental Services, Monitoring and Referral. So once we collected the data, we had to do a pre-analysis just to make sure that the data is reliable. And we use the Cronbach's alpha, we got 0.5. Normally in research, a number of 0.72 is good. So we established that the data was reliable and also valid at a point of 92.1%. So that done, it gave us the go ahead to do the data analytics and see how complete and valid our data was. So for us to see completeness and consistency, we had to have a reference standard, which was non-existent. So we had to design one. Just to be not technical is to say, if injera tastes this nice, you have to compare it to the best injera, isn't it? So you say in terms of the spices, the temperature, and what to say, yes, this is a complete injera. Okay. So we designed a research tool, which I'll display on the screen. And these parameters or components in the tool to say, yes, this data is complete or near complete. We got this from various studies on electronic medical records all the way from the UK, the US. And these 9 aspects were constant in all those studies, and those made us create this research tool. So the 9 components from chief complaints, history of presenting illness, past medical history, habits, there are quite a number, so we picked the ones that were most high risk, including smoking history, oral hygiene habits, how they control the plaque. We know plaque is the dentist's main enemy. Patient examination, if the systems are reviewed, we know there are very many systems, but for purposes of the research, we pointed towards diabetes. We know it has a very good link towards oral health. The diagnosis of the patient, the treatment plan, and the clinic to which they're being referred to. So in these 9 components for completeness, we had it either indicated or not indicated, scored 1 or 0, and we were able to see how complete was the data and which were the areas that were missing for us to be able to improve. Okay. So we begin with demographics of the data that we did. The county that I work in, generally they are young people, as you can see from the data. Majority of them were between 45 years and below, okay, with majority of them being between 16 and 25. We're having a lot of girl power, so majority of our patients were female, 52.7%, and male, 47.3%. I don't know, interesting enough, in most dental studies, the females are more than the males, so could be the ladies are more keen on having a good smile. Yeah, okay. So in terms of completeness, using the 9-point research tool, I'll display our findings. But first of all, we'll begin with definitions. This was by Wiskoff in 2013. That completion is when you have all the dimensions of this data in terms of what it should have, how extensive, the grading, and what. And it has to be done against a reference standard. So you don't just say this is good data without having a reference standard from which you compare with. Okay, and at that point in time, your reference standard is considered as 100%. So you'll say the completeness of this data is X percentage based on the reference research tool that I displayed, or the one that you would design based on your research needs. So overall, we out of the 338 records, 19 of them had missing records, which made 5.6%, which was not too bad for completeness sake. So we'll have to find out how we can tailor make this to reach 100%. And I'll display the findings there. So you can find in terms of age, chief complaints, all the way to treatment plan, most of them are between 19 and 21 consistently, giving us that percentage of 5.6% of records missing. But as much as 5.6% may sound as a small number, that risk factor, if missed, may really impact on your patient. So in case maybe if Kasaum is diagnosing a patient and part of that 5.6% is the patient's smoking history, you can imagine the impact on that patient. So you should always strive to be as close as possible to 100%. Next, I'll talk about consistency. How even were the records in terms of the research tool? Were they having all the same information in each data that was checked? Unfortunately, the level of consistency varied greatly. So some of them had complete records, some of them had half the record in the individual data. So it varied between 5.9 to 95.9%. So that was not good. We'd rather have the records having the same questions asked consistently. And that also has a bearing on the type of software that we used, because it was just open and the clinician just had to type whatever was reported by the patient or whatever the clinician asked. And that's why we harness technology and come up with systems that say the clinician has to ask this question, the clinician has to enter this amount of data, so that you can have consistent records between each patient that is seen. We carried out something called a Net Promoter Score. It's a research tool used in marketing when you want to see what are the factors that encourage a customer to buy this rose. Okay, so you just to explain it, you count the number of scores that help the customer to buy the rose against the ones that influence the patient or customer not to buy the rose. It's a very complex way because humans think very differently. And what we do is we just subtract the ones that indicated from the ones that didn't indicate, to say that's the Net Promoter Score, because it's a mixture of qualitative and quantitative aspects. So we say the NPS of, let's say, Dr. Fassi of buying this mobile phone is 95, because you can't really say exactly what made her didn't buy this mobile phone. So from the NPS, we found that oral hygiene habits had the lowest indication rate at 5.9%, meaning there were more restrictors to our clients being indicated that they had the oral hygiene parameters, and the NPS was negative 88.2. So that points towards where we can intervene, either using technology or improve on it. From the record, smoking habits were not consistently indicated. And remember, this is considering the aspect of sampling errors. So maybe the records we collected didn't have the data, but it still indicates an area of improvement. All right, so consistency, how well you hit the target when you do your research. Let's erase this. Okay. And that's a summary of the records in terms of which ones were indicated and not indicated, plus the NPS score. And you can see chief complaints were the highest at 91.7. So meaning there were more drivers for clinicians to indicate the chief complaints of the patients, and lowest in oral hygiene habits. So it can tell us that maybe as dentists, we're very sympathetic and we are focused on what the patient complains, less than hygiene habits in terms of prevention and care for the patient. So in conclusion, I think we're still in time. Yes. in conclusion, we can say now that if you have good records in terms of electronic records, they really drive improved quality of care, not only at a clinic level, but at a hospital level, a regional level in terms of healthcare management. Plus, when you're doing your research, of course, you need good records. Instead of flipping through 3,000 pages, trying to pick out different people's handwriting. So there's a very huge potential in terms of improved healthcare when we have the good records in place. So we encourage everyone to have good systems in place, to sit in teams, not only in one region, but maybe as a country, so that we design very well a good architecture of an oral health form. And we know that dentistry or oral healthcare or healthcare in general is improving in each year or each 5 years. So the system should be able to be improved so that you keep on maintaining your quality in terms of the data entered, safety of the data in terms of security. We know there is hacking, and so that we can not only meet but surpass the requirements of the data. And this we did. We created a bespoke system for the hospital, and we have been running it for a few years. Of course, there are always challenges when you're running a bespoke system, and so far so good. So we hope that you will be able to review your current processes. We know Clinic X and Clinic Y may have their online digital systems, but hopefully we can get together and have similar systems so that if you're doing a regional assessment on the impact of disease, we have good data instead of doing estimations. So as we do this, let's make sure that the records are user-friendly, something that came up from most of the articles that, yes, there's a lot of information, but it should be easy to enter the data, either by having drop-down menus or friendly icons that clinicians can just click and enter the data instead of having to type so much. Okay? And on the other aspect, that it should be patient-friendly. Unfortunately, with technology, even if you go to a restaurant, you'll find almost everyone like this. They're on their phones. So it must also be patient-friendly so that you're able to type either using voice to data software, so that you're not constantly on your screen typing and ignoring the patient as you collect your data in your systems. I hope that is clear for everyone. So I hope this research and webinar was informative and drive us towards improving our systems. If we have EMRs, if we are on paper system, how we can move to hybrid systems all the way to fully electronic systems. Yes, we know it's quite an investment, but the improvements and the convenience are invaluable. So we'll make a few recommendations, 2 recommendations, one for clinical and one for research terms. And so first recommendations is improvement for practice. And this, I think I mentioned that these records, if you collaborate with the ICT, and most of them are very helpful, the designers are good. Once you tell them, I want this information in this way, I want to click this as mild, moderate, and severe with one touch of a button, with graphics and analytics, not only in healthcare, but also in finance. And if we're able to improve in consistency and completeness for purposes of this research, we'll be able to get this data interoperable. So if, let's say, internal medicine wants to know how many children have this level of gingivitis, so that we can prevent infective endocarditis, it is easy to have data that is interoperable between specialties, not only in dental healthcare. So we mentioned that this platform should not be rigid. Tomorrow there will be a new Microsoft software and should be easy to use. So the health landscape is evolving each and every year. So ensure that the systems can be adjusted to match. I mean, one day we had 1G internet and now we're up to 4G, 5G, and 6G soon, yeah? So keep improving and keeping in mind the future. Right now we're having this webinar to sensitize, and we should do this continuously so that we can improve on the push factors or the promoters towards having good quality oral health data. Next is a recommendation for further studies. You can see some marks on my screen. I don't know where they're from. Okay, so for further studies, we hope to have larger studies, larger a wider scope of implementation of this so that we can have regional good quality oral health data, including all the way to user feedback, so that even the ones using the platforms can tell us, okay, this is, can we use this language? Can we use this classification? So that we can have bespoke systems that can also match the global standards, and we can speak with the same language as we did during the various pandemics. We also recommend for future studies that we have integrated systems, so we can also link with systemic diseases that affect oral health care, so that it's easy for us to say this oral health or oral disease impacts these systemic diseases in a certain way, instead of having to do the actual research itself. So if we're able to implement this, not only in our various countries, we'd have regional blocks that have speaking the same language, same classifications, and hopefully someday the entire world. So hopefully we'll have also studies to establish what is the impact. We have moved from paper records to semi-digital to fully digital, and we've used them for X number of years. It would be good to also see what is the impact. Is healthcare improved? Is patient perceptive? Are our employees or us as clinicians happier with the system? So data, 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 all the way to the end, yeah? Good, that said, we'll show you a sample of a form we designed. This is just a draft in terms of the hard copy. And so with my bias and love for periodontics, of course, it had to be a periodontics clinical form. I won't go through the whole of it, but you can see the format of it is designed in a way that you really don't miss the key aspects of the data, from dietary habits. Are they having high sugar in the diet? How often do they practice the oral hygiene in terms of frequency and types, the medical history, family history? So it has blocks that are important in line with periodontics, because this, we moved from the first encounter and then designed specialty forms. So you'll find that the examination is more inclined towards periodontology. For the perio guys in the group, I'm sure you'll be smiling, all the way to gingival biotype, masticatory dysfunction, the probing chart that most clinicians don't like, you know, lab tests, radiology, all the way to the current global staging and grading of periodontal disease with the modifiers. And you can see from staging, all of us will be speaking the same language. If I get a phone call from Adi saying I have a patient with stage 2, grade A, with modifiers of 0.25 to 1% bone loss, we speak the same language instead of just saying it's severe, it's too much, it's a lot. Yeah? And the modifiers are here. I'll show you. You can see smoking and diabetes. You can do it on the screen. Get my pen. Okay. You can see smoking and diabetes featured there in terms of the global classification, number of cigarettes, and the HbA1c levels. Yeah? So that actually helps us to speak the same language when you're speaking to patients. And these sections are actually mandatory, so that before you move to the next segment and enter data for the patient, you must have mentioned the staging, the modifiers, the systemic illness, all the way to the comprehensive treatment plan. And at the end, the interviewer enters the details for accountability and follow-up. So you can see that's so much work, and that was my push towards rolling the ball on improving data quality in oral healthcare. And this started as a clinic thing, became a directorate thing, and ended up being my master's research topic, 2022. And I've shared it with you. That said,